Thank you very much for the invitation. I do hope that this description of this case is of interest to you. And I'm going to give this with the slant from the Organ Procurement Organization. ODT is responsible in the UK for the procurement, the characterization of deceased organ donors, and also the offer of the organs. We also commission the retrieval teams, but we do not commission the microbiology laboratories that do the microbiological characterization of the donors. So this is just to explain where I'm coming from. Okay, so let me see. Oh, I move it there, okay. Right. So I'm going to go straight into the case. This incident was reported to us in 2015, so that was last year, via the online system, reporting system that we have in place. A transplant center notified us that a kidney recipient had a removal of the graft following an episode of bleed. From that particular recipient, Candida albicans had been isolated. I'll go through the details of this in the next few slides. And they were aware that a recipient, another recipient from the same donor, the common donor, in another center had also suffered from an invasive fungal infection, and the organism isolated was Candida albicans. So that triggered the decision for them to then notify the case to us. That was precisely on day 35 post-transplantation. So what about the donor? She was a 21-year-old female patient who had died of a hypoxic brain injury secondary to hanging. She had had mental problems for a considerable length of time and spent most of her life in a mental health hospital from where she had come straight from. She had had several hospital admissions in the past due to complications of foreign body ingestion. 2 weeks before she had been admitted for the last admission, she had been treated for a presumptive urinary tract infection with 2 days of antibiotics. She was declared brain dead very shortly after her admission, and within 48 hours she then became a multi-organ donor, organ and tissue donor. So, what about the multi-organ retrieval? We had the presence of the abdominal retrieval team only. Usually, of course, if there are thoracic and abdominal organs donated, we have different teams. The reason for this is because the heart and lungs, for obvious reasons, were not used for transplantation. So we had one team attending who then retrieved all organs. A foreign body was noticed in the small bowel, described as being a pencil, perhaps of 8 to 10 centimeters in length. The mucosal wall was visually deemed to be intact. And this is just for information for your out of interest, that when retrieving the pancreas, and this was a pancreas, both kidneys and liver were retrieved from this donor, as well as the heart for heart valves. In doing so, the duodenum must be stapled and cut. So this is just a background to what happened afterwards. Organs are normally flushed. Well, normally they are always flushed with a perfusion fluid or a solution, which I'm going to be referring to PF as perfusion fluid from here onwards. And the organs are then maintained during the cold ischemic phase. These are not our pictures, but I just put it there out of illustration for you to see what actually happens. The organs go literally inside a bag, a plastic bag containing the fluid. Then from there into an ice box. It's just basically a picnic box. The retrieval team, the surgical team, brings all the material, including the perfusion fluids, the bags of perfusion fluid, the ice, the box, everything comes with the team when they actually fly or drive to distant places to retrieve the organs. So, question number one. As regards to the role of culture of the preservation fluid, indicate all that you think apply. A, microbial culture of preservation fluid is of proven clinical benefit and is cost effective. B, the precise risk of infection when the preservation fluid culture is positive is unknown. C, culture of the preservation solution is recommended in the UK. And D, the positive predictive value of culture positive PS is high for infection in the recipient. No? Right, the precise risk of infection when the preservation fluid is unknown. Yeah. That is what the literature tends to say. And this is more interesting for me than probably for yourselves who are experts in the field. Now, so what happened then? As for the right kidney recipient, and this is the transplant center that reported the incident, the preservation fluid was cultured and no organisms were isolated. There was an intra-abdominal bleeding on post-transplant day 15. The patient went into a theatre, but the abdominal wall was closed. But unfortunately, about 10 days later, there was an acute episode of collapse. The patient was bleeding acutely, and the graft was lost. I believe that during this first episode, cultures were taken from the peripheral blood clot, and that grew Candida albicans. The patient was commenced on fluconazole. The precise date that is unknown to us, and the transplant team, as you know, had informed us of that event on day 35. The other transplant center B, where the left kidney and the pancreas went to, the preservation fluid on this center was cultured. And the two organs went on two separate bags. Both fluids from both bags grew Candida albicans, lactobacillus, and cerevisiae. The patient, as a result of this result, was commenced on day 5 post-transplant on 7 days of fluconazole. There was an episode of a need for an exploratory laparotomy on post-operative day 10 for this recipient due to abdominal pain, and circumstantially also there was a knowledge of raised white cell count and array C reactive protein. Nothing of significance was found. Internal abdominal swabs were taken, and there was isolation of Lactobacillus rhamnosus from this swab again. Overall, the patient, the progress of the patient was satisfactory, and eventually the patient made good progress. So there were no further complications that we know of. So at this point, the liver transplant, in terms of the European picture, and in the context of liver transplantation, because of the higher risk of Candida invasive infection in those patients, anti-fungal prophylaxis, consider anti-fungal prophylaxis in that context. Due to the increased risk of invasive infection, the commonest practice in Europe and available evidence suggests of what? Universal prophylaxis, amphotericin and fluconazole being of equivalent efficacy in this circumstance, or people might prefer targeted tiered prophylaxis as opposed to universal prophylaxis, or prophylaxis with either fluconazole or amphotericin B does not reduce the incidence of invasive fungal infection in those patients. Oh, that's interesting. That is quite interesting. Right, okay. So we won't have time to go through what's out there in the literature. I have put some references in the slides for reference. I mean, this is due to is a meta-analysis that was done very recently. I think it was published last year. Okay. Not to say that people are using amphotericin in those circumstances. So, liver transplantation and antifungal prophylaxis, and this is just some figures for you. Is not really the scope of this talk. Should be talking about what actually happened afterwards, but I thought that was illustrative. So, there's an audit run by ELITA where 128 centers were sent questionnaires. The 50% response rate, with 8% saying that they actually use prophylaxis in those circumstances, 35% as universal, and 53% as targeted in terms of a tiered risk according to some risk factors criteria, and the vast majority using fluconazole, as you probably know. ATS, by the way, in their guidelines, they do not recommend systemic prophylaxis in low-risk recipients. Again, is this classification of risk factors as opposed to universal prophylaxis. The practice in the UK is variable. So, what about the liver recipient? That's a transplant center C. This center was not routinely at the time performing microbiological culture of the perfusion fluid. The recipient therefore had not received antifungal prophylaxis, and neither did the recipient fall into the risk category for prophylaxis, otherwise the person would have been on prophylaxis. The implantation required also an aortic conduit, and the iliac artery of the same donor was then utilized. The patient suffered a very acute presentation, had a ruptured pseudoaneurysm aneurysm of the aortic conduit, and that was day 23 post-transplantation, and died. So, and the culture of the vascular tissue, and histologically as well, there was evidence of Candida albicans. Now, as a result of when we started our investigations, and it became apparent the transplant C volunteered another patient who coincidentally had been transplanted about a month earlier. There were some concerns about it because the cause of death was exactly the same. The organism isolated was the same, Candida albicans. And there were two other coincidental things that they didn't know at the time, but when we looked, it was the same surgical team that had retrieved had been present at both retrieval episodes, and two batches were used in terms of perfusion fluid in the first case, and one of the batches was utilizing the same batch was also utilized in this retrieval episode here. So, I'm just telling you what we were collecting as we went along. I know I'm presenting things in a way that all sounds very obvious and easy, but the information here wasn't available to us in this particular order. So it was a rather complicated thing to piece together. So the tissue bank, the heart valves went to the tissue bank because, as I said, the heart lungs were declined on the basis of function. So there are very stringent protocols in terms of tissue utilization. They have the luxury, so to speak, to actually prepare the tissue and make it as safe as possible, which obviously is not the same with the organs. So we were very happy with that process. Nevertheless, we verified everything. So what they do actually dip the heart valves into a cocktail of antibiotics, they always take a sample of the fluid pre-disinfection and post-disinfection. So the pre-disinfection fluid grew Lactobacillus rhamnosus, which I thought was actually a nice coincidence. But no other organisms were detected, and the pre-disinfection culture was negative. Now, so the initial considerations that when all this happened, and this came along, I think I was phoned on a Friday. It was literally Friday. It was about probably 4 o'clock. So some decisions had to be taken rather quickly. So what we had there, we had the possibilities that we consider were a donor derived with graft contamination for the gastrointestinal tract, by whichever means that might have been. An environmental source such as the melting ice machines, surrounding surfaces, and the organ transplant boxes. We're not putting here in any order of likelihood at all, and some of that, I'm sure you will agree, were probably very unlikely to be, but we needed to be very, very broad in our approach. The organ preservation fluid, because of the fact that we were seeing the same fluid potentially implicated in two different events. Coincidental finding, a completely coincidental finding, completely unrelated to strains of C. albicans. At that point, the several different authorities had to be informed, and the manufacturer of the preservation fluid was also informed. And they actually, we put a quarantine of all the those 2 batches in the whole of the UK, but the manufacturers put a global hold of the product, which is quite a big thing to do. So, in terms of the multi-organ donor and the retrieval itself, I then contacted the donor hospital, spoke to the microbiology consultant there, and we then established that there were no samples available from the donor for confirmation of Candida albicans colonization. The samples tested at the time of admission were very routine. Her hospital admission was very brief, and there was no other reason otherwise to have had other cultures. So because of the recent history of UTI, she had a urine sample. There was a genital swab of no precise site declared because there was a vaginal discharge on history on admission, which I was interested, but that really didn't lead us anywhere. And the routine screening for ESBL and MRSA, as you know. There was nothing really there that gave us any clue. Now, in retrospect, we did look at all the surgical reports of the retrieval team, but in retrospect, on interviewing the chief surgeon, then it transpired that there had been a small breach of the fundus of the stomach wall at the very beginning of the retrieval operation, with a very small volume of gastric content being spilled and rapidly contained. So, jump straight into what we did. So this is just part of the investigation. We received closed bags of the perfusion fluid. We received them separately in our national reference laboratory in the blood services, and other 2 bags went straight to the Myco reference lab in Bristol. And they performed the following tests: microscopy in culture, the beta-glucan antigen testing, and they run a pan-fungal and also a candida-specific PCR. Those results were all negative. The cultures were also replicated in our laboratory. And following all that, the products the quarantine was lifted. We didn't have any of those products in use anymore in the UK, so for us that wasn't a problem. But so much so that the bag that we received for testing was actually a bag that came from Switzerland. So the environmental swabs, which one might have thought that was a bit excessive, we didn't really have much to go for, but some people involved in the investigation were very keen to look at ice boxes and fridges. So we then asked the transplant center where the surgical team originated from to collect some environmental swabs for us. And under our direction, one of the technicians did that, and the swabs went straight to Bristol. So, and this is what they got. By the way, of course, the organ box was not the organ box that it was used on the night. They are recycled nationally, so it was impossible to trace which. But on the premises that if there had been any contamination, the contamination would be environmental and would be quite obvious, and it would probably pick up in the environment. Now, so this is the more interesting bit. I hope you can. Well, there's not much information there. I can just say that, of course, what they see in the 2 boxes is that the pointer is not great, so I just, the upper box is the liver recipient and the kidney recipient related to organ donor number 1, which is the one that we are discussing now. We had 3 samples that we were able to recover from the transplant centers who had retained the isolates. The isolates from the kidney and pancreas center had not been retained, so we didn't have that to analyze. Then what Bristol obviously did, they just went through the whole process of confirming the identity of the organism in the first place. So simple things, first things comes first. Yes, Candida albicans was confirmed, and the MIC was, they thought that in a very quick look and see, there was a possibility that we would get something standing out. So, but they were all sensitive to all drugs tested for. And this separate one is the second liver recipient from a different donor. And by the way, that was a single organ donor. There were no other recipients involved, which made our work a little bit easier as well. Otherwise, we would have to go and look at those as well. So, once Andy and Liz in the lab, and I think there are people from both labs here, they prepared the pure cultures and swiftly shipped them across north to Aberdeen, and there Donna McCullen very kindly agreed to speedily perform the MLST for us, which really we thought was the only way that we could really tease those things out. So I'm not going to really mention anything. I think I can skip this slide for this audience here and go straight to the results in the interest of time. So I do not know whether you can read it because I can't, but the MLST done there in Aberdeen looks at the several different PCR projects, and they assign a number in terms of the allelic differences for those different loci, and by the way, she received all the samples blind. She really didn't know the identity of anything. So when he came back, I then opened opened the labels, and you're all fitted in an easy way because the profile and then the DST, the diploid sequence type, was assigned on the basis of the differences here. So these three isolates here were assigned 2941, and the other isolate here, the two isolates that we had from the liver recipient, was 2940. So there was a very high degree of confidence that you were talking about a different strain here, and we were very pleased to hear that. Otherwise, that probably would have unveiled a much larger problem that we thought initially. And also out of interest, I mean, those DSTs were not, they were new. They were newly described DSTs. Again, we thought that was quite interesting at the time, but looking at the literature for very few in terms of publication, people who actually have tried to work the imputability from donor and recipient by using proper molecular techniques. Usually when they do that, is always because of the diversity of the Candida species, you always find something that is different and is new. So, because Donna was saying, well, you know, we don't have those sequences in the database. They are new, they are unique, but that seems to be the pattern. Okay, so of course, I mean, in considering where that could have come from, and that was our mission for obvious reasons. So considering the endogenous and the exogenous routes, and usually the contamination of the preservation fluid at the point of organ retrieval is always believed to be the commonest source. It's always proposed, it's circumstantial, and if you read the literature, it sounds all very logical, but in terms of, as I said before, in terms of proving, an absolutely proven donor imputability, there isn't much out there. It's very circumstantial, you know, and there's some nice papers. Levesky paper is actually a quite nice one to read. Okay, so question number 3. In terms of the microbial contamination of the perfusion fluid in abdominal multi-organ retrieval, we're not talking about thoracic, cardiothoracic here, there is evidence that indicates all that apply. Infection occurs less frequently in recipients who receive antimicrobial therapy with activity against the isolate in the PF than in those who do not. B, infection with organisms recovering from the perfusion fluid culture is commonly associated with significant morbidity. C, when infection develops with the organism identified in the perfusion fluid, the morbidity is high. And the rate of positive culture is quite variable, but largely at less than 20%. What do you think? okay. I mean, I think, okay, number A is probably stating the intuitively obvious, isn't it? Infection with organisms recover from, there you are. That's what I was waiting for. I probably will have some slides touching on this, so I'll just go along because I have not long to go. Okay, now, there we were asking about contamination in the broad sense. Here we are talking about yeast contamination because that's what is relevant to this presentation. So as regards to yeast contamination of the preservation fluid in abdominal multi-organ retrieval, the overall rates reported are very, very variable, but what do you think? A, B, C, or D? You might have a very good idea, or you might just take a guess. It's low. Wait, low, I don't know. I regard it as low. And I think that, and this is doing a literature search and seeing what people were publishing. And this, I thought, had quite a significant relevance to the fact that when discussing this situation, the argument that keep coming back and back again is that the positivity rate of PF is too high, therefore one can't handle this. We don't know what it means, we don't know what to do with the results, and then my argument was, well, it's not when you look at what really matters. So it depends on when you start classifying and stratifying the organisms that you are actually isolating from the PF, those that matters from those that don't matter. Because of course then the next step would be ODT, us as the organ procurement organization would like then the transplant centers who are currently culturing, when you do have certain outlets, to report back to us. And that was a big discussion that is still open there as to whether that's the right thing to do or not. So I've got my own opinion, but I don't know what the overall result is going to be. Okay, so the conclusion of our investigation was that there was strong support and evidence for a common source of Candida albicans for the right kidney and the liver recipients. Linked to donor number 1. The characterization of Candida albicans that we managed to perform indicates that it's highly unlikely that the same infecting strain in the 2 recipients had occurred just by chance. I know this all sounds very repetitive, but when one writes a report and the level of sensitivity around this case is high. So we need to be very clear about what we are actually saying and why, and provide the evidence for that. That would stand if challenged legally, etc. So now this is just a by the by, to be quite honest. This was an interesting that the recovery of the same species of, and that not the Candida, referring to the lactobacillus, in 2 different centers. You know, one in the tissue bank and in transplant center B, probably helped us kind of have supporting evidence of the likelihood of surface contamination during the retrieval process, because there were still questions made as to when that could have happened, and even questions as to where exactly in the GI tract that strain could have come from. So that's the level of scrutiny that one gets under in terms of trying to then provide scientific responses to that. And because there had been the breach of the gastric wall. Now, so what do our guidelines say? Here we have the European book guidelines, and I think the next edition has already been written. I don't know whether it's been published. I haven't seen it yet, and I'm sure you can't read that, but it just says that the perfusion fluid should be, look at what they say, the contamination of the perfusion fluid should be avoided, and this fluid should be monitored with repeated sampling for bacterial culture. So I don't really know what that means, but that's what they say. And then SAPTO, our old good SAPTO guidelines, and this is the current version, is still in use, do say that we should be culturing the perfusion fluid, and then use discretion, interpret, and if you think that is a significant pathogen, take action. So basically it leaves, of course, the decision making to the transplant center, which sounds all very reasonable. Just as an aside, but probably relevant, we are rewriting the SAPTO guidelines as we speak. And as of now, I don't know the end product, this has come out. So this is no longer there at the moment. Maybe the group is taking the view that there isn't sufficient evidence to actually ask transplant centers to do that, but this may be controversial, and I just thought I'd share that with you. So points for consideration. Overall, the interpretation of culture results may be challenging, and I'm trying to be very neutral here. The clinical consequences of fungal contamination of perfusion fluid are not completely understood, and the literature on this topic is controversial. A lack of randomized control trial data, if that is possible at all. There are lots of single reports, and there's a huge variation in methodology, not even to mention the laboratory methodologies used by the labs in terms of even looking at Candida and the possibility of even isolating yeast. The infection transmission from contaminated solution appears to be uncommon, although, and depends on many variables, so it's a rather complex situation here. Invasive Candida infection is correlated with positive perfusion fluid, and that's a fact. So not all positive cultures will then result in an invasive infection, but when there is an invasive infection and you go back and when people have cultured it, the culture would have been positive. So, and the UK practice is very variable. From not culturing at all, from culturing and not knowing what to do with the results, and from culturing and then using a discretion, classifying the risk, and then managing the recipients accordingly. And that's more or less what Transplant Center B is currently doing. So that's for my own benefit. To culture or not to culture, what is your personal opinion? So do you think that the severity of the invasive Candida infection justifies culture to inform appropriate management of recipients, or do you think there is insufficient data to support the utility of culture? Yes or no? Yes. No, sorry. There's another question I'm stating. So, culture or not to culture, yes or no? Sorry. Good, I shall take that back and see what that makes a difference. Thank you very much, and sorry I went 2 minutes over time.